All right. So, case like we're going to be going through: 30-year-old female, a woman complaining of neck pain, headaches, referred for treatment. Uh, she gave a history of being involved in a motor vehicle accident when the car was driving struck from the rear 2 weeks earlier. She's experiencing mild posterior neck pain. So we have experienced mild posterior right neck ache almost immediately. By the next morning, cervical pain was much worse and accompanied by a right occipitotemporal headache. So, Chan, being top of my list, buddy, what do we know about her already?
That you just asking basically NBA 2 weeks out, neck
2 weeks
pain,
out,
neck.
right mild posterior neck ache almost immediately. Next morning, cervical pain much worse and accompanied by right occipitotemporal headache.
Uh, do we know immediately?
You know, right now, what assumptions can we make? What are we thinking?
Well, a little bit as far as a red flag, as far as the immediate neck pain, as far as MVA, and then you're looking at the headaches. A little bit of a red flag there. So I'm going to just go upper cervical disc. Immediately, I'm a little bit concerned about a fracture.
Okay, so we're concerned. Let's say fracture. So in your mind, you're thinking, okay, I've got fracture in my mind or something more serious. What would a fracture look like in this individual? What would you expect to see?
Uh, I'm thinking either C2 possibly.
It doesn't even matter the level, let's say.
Okay.
But if it were C2, again, what would you still be seeing if it was C2 or C3? What would you expect to see in this individual with a cervical fracture?
Um, the way she deviation of her head or deviation of her neck, possibly.
Okay. So fixed deviation.
Yeah.
Good. Anyone else have any thoughts on what they would expect to see with this individual if this was a cervical fracture?
Definitely some sort of range of motion loss, maybe in one specific direction.
Yeah. Yeah. Most likely all directions.
Dave, is it safe to say they won't want to move it at all?
Yeah. You can see that this person is going to splinting. Range of motion loss would be severe. Splinting. They're going to put a neck collar on themselves with their muscular system co-contracting. Think about it. So you're going to have this co-contraction splint around everything to kind of clamp the upper neck down. C1, C2, again, as Chan said, you may see a rotary dysfunction, depending on the individual, if depending on the position of it. But generally what you're going to see is loss of range of motion. This individual will be severe. And how soon does that usually start in this individual?
It's pretty much immediately, right, Dave?
Yeah. Immediate severe pain, range of motion loss is severe, potential for fixed deviation going on. Anything else indicative of a fracture?
If it's severe enough, could she have any neurological symptoms potentially?
Yeah, I mean, severe enough, you may have, again, yeah, if it's severe enough, absolutely, you could see neurological. It may not be an absolute. So, you think about it, it could be like a plus or a minus. Like this person has neurological symptoms. I'm feeling even worse about this. Again, you can't then eliminate, a disc wouldn't, an acute disc trauma may give you the same things, but either way, you're kind of in the same boat where, okay, I can't exclude a fracture, but if it's a severe sudden disc injury, we're not in a good place either. So you can have plus or minus radicular symptoms in this individual, depending if you're adding in neural compression. So it may not be a component of it all the time. A good way of thinking about it. That's like a plus or minus category. But it doesn't make me feel any better if they have it. That's for sure. Any other hallmarks of fracture?
I know this person has right-sided pain, but isn't it typically like midline tenderness or midline pain?
Yeah, and it may be more midline would be one thing. So, that'd be one thing. If this person has midline pain, fixed deviation, severe range of motion loss, immediate severe pain, radicular symptoms, midline, yeah, it's going to do it. If it is severe if I have severe midline pain, it's still going to make me think fracture. Unilateral does raise the question of, unilateral structures usually cause unilateral pain. It's kind of a general rule of thumb you can think of. Medial structures tend to cause, midline or bilateral symptoms. So if you think about that, the midline would strengthen this illness script. So this is what we look for. So if we're thinking, okay, my differential here at fracture, this is what I'm gonna be looking for. So this person apparently went home. They apparently went to sleep, and they apparently woke up with more neck pain and a suboccipital headache. So how's that feeling for the fracture? It's in there, it's in your differentials, but it may not be my first one. I want to account for it in my thought process.
Dave, my H1 would be VBI. I need to rule it in and rule it out.
Yeah, you could put VBI in there. I would probably put VBI in this one in my list of differentials, because what I have to distinguish here at this point is they woke up with right suboccipital headache, which was okay. Cervical pain was much worse, accompanied by right suboccipital headache. Let's go into this again. We have pain is worse, and headache. What would be the next step to do to try and differentiate this potentially being VBI from cervogenic pain?
You want to see if the neck pain and the headache are coupled or not.
Bam, look, somebody's been listening. John, who's on John's microphone?
It's on my microphone. What do you mean?
Well, it's your name up there, but it couldn't have been you answering that question.
Gotcha.
Yeah, it's coupling and uncoupling. So how do you understand that, John?
The way I get it is you got to ask them if they both occur at the same time, or if one's severe, how severe is the other one, trying to get an idea of if they're paired together, or if, one's present and the other is not present. And you can say, well, maybe it's not decoupled then, or maybe it is decoupled rather.
Yeah. And so that concept of, okay, is the cervical pain coupled? The cervical pain is worse, and I have the headache. Hold on a second. Have Tori coming in here with me a bit. That meeting was. Hey, Tori. That meeting was supposed to be tomorrow. I think my date screwed up. I'm teaching right now.
Okay.
Is
No worries.
tomorrow possible?
That's fine.
Or if you want to hang around, listen to me babble, I have time after because I had a cancellation, but I don't know if you have time.
What time was that?
2?
Let's just go tomorrow.
You okay tomorrow?
Yeah.
Okay.
I'll look
I'm so
tomorrow.
sorry about the
It's
confusion.
okay. Don't worry
No,
about it.
I
You can
apologize.
always read the email then. so
Okay.
No
No,
worries.
I think I should be specific. Like, here's the date and time, not tomorrow or yesterday.
No, I
Sorry.
put it 10 minutes away, so you're good.
Sorry, I'm overbooking myself, guys. Okay. Take care. All right. So coupling, uncoupling of the headache is the key indicator here. With that, so I've the cervical pain is worse and my headache is worse. That's a coupled pattern that would most likely indicate that, okay, there is a cervical involvement. If this is uncoupled, where my neck, I don't notice the neck pain increasing, but my headache is progressing, then in that aspect, I can't write off the headache or the headache occurring from the neck. And that's that idea of coupling and uncoupling. Now, it doesn't mean that I can't have increasing cervical pain, increasing right occipital headache, and still not have a bleed or dissection or something else going on. But what it would most likely indicate is that, okay, I can kind of start to keep looking at this. But once I have that uncoupled pattern, then I really have to start thinking, okay, stronger about, okay, is there something else more centrally causing this headache to occur other than something in the upper cervical joint or craniovertebral region? So in giving this, hearing the sentence, that idea is that, okay, I have a right posterior ache immediately. It's unilateral. I have next morning, I have worsening pain accompanied with right suboccipital headache. This is a VBI, Kevin. What would the VBI most likely look at? What would I want to look at next with it? If I was willing to look at something next to say, hey, listen, neck pain's coupled. Don't think it necessarily is, but I don't want to do anything else until I'm a little bit more sure. What would be the next step? Or what else would you look for in this individual if you're thinking that they're having a VBI? Haven't run away already.
No, I'm here. I'm thinking I'd love to be able to push on the joint. I'm just not comfortable putting my hands on them yet.
Good. So what can you do simply to do first step? They're having a VBI. What would you expect to
Ask
see?
them about other symptoms, looking for the 5Ds, any other red flags, subjectively screening them.
Yeah. What screen would you do to them if they were having, let's say, the 5Ds, or you want to look at something that was going on? What screening test generally could you do?
Could you run through cranial nerve exam?
Yeah, cranial nerve exam is a good one to start, because any one of those 5Ds are all cranial nerves. Essentially, you could get you think, I'm not quite sure. Let me get a baseline cranial nerve exam. Because you get a positive cranial nerve exam in a neutral position, and not only after I finish tinkling in my pants a little bit, I'm going to kick them off to the hospital or somewhere, because that's a serious condition. They're having a stroke or VBI. I can't write off cranial nerve symptoms. I'm seeing cranial nerve changes in neutral, any of these, and that's my definite red flag to kick them off. Now, that said, be having something going on and you're not seeing it. Now, normally a lot of the testing that we'll talk to when we talk premandibular holds and positioning is going to be looking at, am I occluding the artery with positional tests and then doing cranial nerve tests? And we're going to do that during the lab session. But understanding a baseline cranial nerve exam here, if I'm curious about it, will be helpful. At least, and then excluding that, okay, right here, right now, I'm not missing something obvious. So cranial nerve exam, good step right here to see where are we. Now, we're not indicating manipulation or doing anything yet, so we don't really need to get into pre-manipulative positions or progressive cranial nerve testing at this point. But we want to see, okay, do I have any cranial nerve signs? Do I have any loss of balance? Anything else that would explain this? That would be that. So VBI is definitely in your differential list. And if I was going to look at this right now with this history, maybe cranial nerve test is something I look at real quick, because I can do that in 10 seconds essentially, and kind of say, okay, I don't see an abnormality here. Let me keep my line of questioning going, to that at any point I can come back to VBI if something indicates it. And say, I'm feeling comfortable, I get in a range of motion, I do rotation, and they feel dizzy or they feel some symptoms going on, or I see an abnormal eye movement, then okay, I'm going to come back to cranial nerve testing and revisit this idea. If I see a change that would imply a cranial nerve change, would be indicative of something that may be a mild ischemic event. So worsening of any one of those symptoms that would indicate that headache is kind of like number one. So anything else for VBI? Cranial nerve? Anything else you've been taught? You're not really at a point we're going to be doing positional testing yet. What other mechanical differential might be in play here? What other differentials do we have? Because our real serious ones are fracture, VBI. Another serious one's infection, but there's, that's really not in here. Just not going to get acute infection from this accident, so we're not really considering that one. So we can move down the list. What else would we see in differentials in this individual?
Ligamentous instability. Really pick any of them, upper cervical.
Yep, ligamentous instability. And there's things we can do for that, right? What can we do for ligamentous instability?
Your LR ligament tests. sharp pursers testing transverse ligament integrity. And then even that though, I wonder, I struggle, Dave, with if it's maybe partially compromised, do I finish the job if I go ahead and load it up? That's anytime I'm stress testing ligaments, if I'm already wondering if they have some compromise there, is it possible I go ahead and finish the job for them? Not something I want to get into, but
It's really a matter of
Your
your
thoughts
mood and
on
how much
that?
you like the individual, but that's neither here nor there. Yeah. And see many people say sharp purser is one of those ones. I'm 90% sure they don't have it, so let me go ahead and do it just to kind of further confirm it. Because generally with sharp purser, if I'm thinking that I am looking for, do I feel symptomatic when I basically do this position? Do they feel like their head is loose? Do they have any predispositions? Is this a 56-year-old rheumatoid arthritis patient who's had it since they were a juvenile? Is there a history of this happening? Because oftentimes they find that like the dens fractures before the ligament breaks, unless there's like a pathological condition that would predispose them to it. So many times the bones will fail before this ligamented system will in doing that. So you get into the sharp purser test, you're probably well sure of it that they'll do it. And in a traditional sharp purser test, you've seen it done two ways in different studies. Jim will be particular about when you do it, it's a reduction test. It's really a movement test. When I go here, if I do the posterior glide, do I feel movement? Versus some of the other tests talk about symptom reduction. That, okay, I do it and I have symptoms and it reduces symptoms. You've seen tests describing two different types of positives. I think the classic one, which Jim tends to stick to, is it's more the reduction motion. There's a motion there versus that one. But the nice thing is you have two tests. You can do it supine. The seated test is preferable, I think, from the data standpoint and some of the early studies that were done, but also that it's a symptom reduction test versus a positive test trying to produce the symptom. So generally that would be the thing you would look to do. You're looking at a nodding test, so craniovertebral nodding, which is actually in some of your range of motion assessment, is kind of essentially kind of the position that you've used for that. So to some degree, at some point, you're going to do a version of it, just not with the stabilizing and overpressure. Does that make sense, Kevin? So I don't do it a lot.
yeah, it does help. I'm more comfortable doing it when I'm pretty sure that it's not there.
Absolutely.
I do like that.
Yeah, absolutely. I'm most comfortable doing it when I'm pretty sure that it's not there. Very seldom do I see somebody where they crap, this is an alar ligament tear, unless there's something in their history. Now, there's RA patients older. Well, I check it periodically, figuring, okay, if I live long enough, I'll bump into one. But I've not seen one positive. Alars, I found one in a course last year, and it matched her symptoms. She had a whole sympathetic. After everyone in the class went through and kind of felt her alar ligament tube, she was a sympathetic mess. So I spent about 40 minutes after the class just resetting her. So just something to keep in mind as we find positives. Unfortunately, it's best for us all not to feel it because it can generate a lot of different symptoms. So ALR is one you'll find. There's other upper cervical ligaments that you'll see with these injuries. I mean, there's everything from dural tears to fascial tears in the different layers of the neck muscles occurs. That can be very problematic and chronic because the neck is basically designed like a tube. And there's these fascial tubes which encapsulate the muscles and allows them to work efficiently. That fascial tube, kind of like the TA attaches around the thoracolumbar fascia, and the TA fascia creates a stable tube in the lumbar spine. We have the same thing in the back of the neck. So if somebody gets an injury to one of those fascial restraints and it gets torn, then the neck muscles are unstable, and they're the ones who tend to develop some of these chronic neck problems from that lack of stability in the different layers of neck muscles. If I'm prepped enough, we'll look a little bit at that because I was curious about it. I make sure that I'm competent in talking about before we get into that. So you have ligamentous instability, but also in those layers of stabilizing fascia. Again, stabilizing fascia, less serious. Alar, pectoral, sharp purser, the big ones we think about when we look at this. And we can do tests for them. What else? Okay, we'll go to the next sentence here. We'll go on. Cervical pain with headache is initially present continuously and relieved only by analgesics. But over the last week, headache became intermittent and prolonged with prolonged flexion positions, such as reading, and she experienced no other pains or paresthesias. What are we learning here? We're learning that cervical pain initially was present continuously and it was relieved by analgesics. What does that tell us? All right, Patrick, analgesics decrease the pain. What does that tell you?
That tells us that that
Anti-inflammatory.
it's maybe an inflammation. Yeah.
Yeah.
And then it
Unmute Patrick. Sorry, hit a button.
it also seems like that they are coupled with the neck pain and the headache.
Yeah, it seems coupled. I take an analgesic, and now I have the reduction of my neck pain. The fact that the neck pain was worse the next day, came on, is a sign that, okay, over 6 to 8 hours, 12 hours every night, inflammation sets in, they feel worse the next day. Headaches are a little bit worse because it's been irritable. I take an anti-inflammatory, I feel better. It kind of helps strengthen the thought processes. Okay, do I have some type of inflammation, that joint, muscle, tissue that may be driving this? Positive effects. Cervical pain present at the end of the workday. Patient's working, so that's a good sign. You're thinking about obligate loss of function of severe disc injury, other severe pathologies. And we have prolonged flexion position, experience with no other pains or paresthesias.
I mean, I want to put my hands on them and see if it makes a difference when you're getting your hands on the muscle. Can you refer the pain? Is it the same as what she's feeling? Like, is this muscle spasmy or is there something else going on? But it sounds like it's a lot of guarding and healing from the accident.
Yeah, I mean, that's kind of, you're feeling better about that now than you are something more sinister like a fracture or BBI, right? That's kind of where you start curious, like, okay, I want to kind of get my hands in there and get some information, correct? But it's kind of like, as we talk about this process, almost like in slow motion, it's like, as you get this history from this patient, this is often the process that we're going through in real time in our mind. It's that idea of, I have all these differentials, and because I understand, okay, what would I be seeing in a VBI bucket? It's not really matching a VBI bucket, but I'm still going to compare this information as I roll down to my BVI script or my fracture script or my, acute herniated disc script or my segmental dysfunction script, whether it's inflammation, acute inflammation, muscle strain, ligament strain. Like, we have these scripts in our mind. That's where we have, they're very helpful as we get information comparing to. And each sentence in this thing kind of helps push me in a different direction. It kind of helps me see it. Like, we look at the next one where, she did not hit her head during the accident, denies being knocked unconscious. They remember everything about the accident. With that, it's kind of weakening the idea that, okay, was this person in some way concussed? Say, it's bringing that information or that piece down. Not that they couldn't be with the rapid head motion, but maybe a little less likely in this history that we're being given. No medical, previous history of neck pain. There's no underlying circumstance that was there. It's up before. And she's not expressed dizziness, nausea, or visual symptom. That is really kind of ruling out that kind of, okay, do I have some concussive head trauma in the argument? Anything else or would strengthen, or what else would also further strengthen, think that, okay, this person was concussed? What else might we see?
Do they have any light or noise sensitivity? Trouble concentrating at work or at home? Are their phone or computer giving them problem? And then the balance, going back to the initial balance exam, how does that look? And then any like trouble word finding or anything?
Yeah, so like, we thought there was a component of it in here. I mean, that's exactly the things I started going through. It's like, okay, at some point, it may not be my high priority list, but I'm thinking, okay, they have neck pain, they have this, there's something else in here that doesn't make sense, or they're giving me a few of these other symptoms. I'll ask these questions just to kind of further rule it out. Sometimes I'll ask them real quick because it takes me 20 seconds. And then when I write my note, the next PT who may see this person will know that, oh, they've screened for these things. They don't have them. So they should be able to read my note because I'm ruling out all these things real quickly in my note. That other PT, I tell the story for them if somebody follows up with me. That, okay, they, this is not, okay, concussion. So that may be later down what I do, but all good things to kind of think about. Here's my script for if I want to kind of do my bias correction now and go through it. Those would be things questions I could ask. It'd be perfect fit given the history that we have here. And again, we see here that her pain is gradually improving. If this was a bleed, what would be the difference in that versus gradually improving? What would we see? If somebody has a subdural bleed, how does that present?
They'd progressively be getting worse.
Yeah, you're looking for things to progressively get worse. So that's why we look at questions like these when Jim does. Every sentence has a little bit of a nuance where you can pull information from it as you get it. So as I kind of get this totality of this picture, it's like it's down ramping, okay, my initial thought process that, okay, this isn't really matching maybe that VBI script. So I'm feeling better in that predictive category that, okay, it's, not really kind of going in that direction right now. I'm really heading into more that other direction where is there something muscular, articular going on? You're getting itchy to get your hands on them. So here's kind of the comments, headache is probably referred from the neck, given that the symptoms are coupled, kind of looked at. We don't really have strong symptoms of necessary VBI supported fracture because of movement. She's back at work. Disc herniation, again, there's not an obligate loss of function, not severe splinting of range of motion going on. The onset was more severe of cervical pain. The onset of headache occurred simultaneously is what we're looking for, that coupling that Don mentioned. Distribution of her headache is typical of a serogenic headache because of the onset and propagation with factors coinciding. And additionally, again, that idea this patient is fully functional, went to work after 2 days. Jim was basically big on collars on some of the ligament ones. I know they're not popular now. It can really vary on where you're kind of trained. Here you can see in one of the cohorts, what we did was we basically put in here that here's kind of some of the differentials of subjective findings of what you would see with these differentials, where we have disc herniation, segmental dysfunction, segmental hypermobility. Of what would be some of these different classifications what we may see. And also, the idea is that idea of what might I see to align my question, and what are my 2 tests or things that I would test that would come in to further strengthen it. I talked about it earlier, upper cervical ligament strain, pain with end ranges, deep feeling of head, looseness, occipital, suboccipital pain, dizziness may occur, type 2 dizziness, which is, not vertiginous, but a disequilibrium. And there you're looking at your ligament stress tests there. So in here is a chart of some of the common differentials if we got to work through them on this individual. And to some degree, we go through a bit of this in our mind, but it's just nice in our mind to have this information as I'm getting that history layered like this to say, I'm going to develop an H1 out of this, but in the back of my mind, I'm going to keep these other scripts handy. And once I finish my exam or during my exam, I'm going to be looking to do my exam in a way that strengthen. Once I say, okay, I think this is a cervical sprain of a muscle, that I can look at these other categories and see that, okay, it doesn't match, joint inflammation because maybe, okay, palpation, PAs, and pivot patterns are negative. I don't reproduce it when I mobilize C2. But if I resist cervical extension or sternocleidomastoid, I get the symptoms. So within there this is what we'll kind of work on. So even in the class we do these cases, this isn't a bad little chart to kind of have handy to think about, okay, I'm going to develop an H1, and then I'm going to bias correct against the others. And if at any point the information changes, what you don't do is don't feel guilty about changing your mind. You just change over like, okay, this is looking more like a disc herniation than a muscle strain. I need to start moving into this pathway. So it's very common sometimes that it'll be your H2. and not necessarily your H1, and I just pivot right away. If you do questions with me or anyone else or Jim, sometimes what Jim will do is classically take you around these. So if he knows that he's going to make a segmental dysfunction and you pick up on it right away, he'll switch it over to a disc herniation. Just be ready for those changes. But also, don't be shy about changing your mind. That's anchoring bias, I believe, if I get my biases correct. This individual extension, was about 50% of the expected range and reproduced her right cervical pain. So when we go into cervical extension on the right side, what is the right facet doing? Scrolling down for somebody. Who's going to give me this one? Anyone?
Going inferior.
Yeah, you have an inferior glide of the superior vertebrae. So let's say this is 5 and 6. Inferior glide of the of that right facet joint. It's also inferior glide of the left one as well. But inflection was, almost full range of the pull on the posterior neck. What could potentially create the pull on the posterior neck?
It's like a pulling could be muscular.
Yeah.
The tissue back.
Yeah, you have muscular tissue guarding. Very common. You'd expect to almost find that in this individual. It could be articular restriction. Does that make sense? So, okay, I'm going to say this is, now it doesn't really, it could be a flexion subluxation, but again, it could be an articular restriction or it could be jammed in a hypermobility on the left-hand side. So there's just also splinting and guarding around it. Oncovertebral joint, as I extend that joint, there's a bit of an anterior glide, roughly a translation. It's very small. So we could also think here, it's like, okay, so I extend, both are extending. There's a pivot of that. So it could be more of an inferior or glide of the superior oncovertebral joint down the inferior oncovertebral joint. Here. See, right side flexion and right rotation about 8%, 3%, effectively. So if we have right side flexion limited, and we know that we have extension of the facet joint, what is the glide of the oncovertebral joint of C5 on C6 on the right? So what direction is 5 gliding on 6 on the right? Inferior medial, and we'll call it superior lateral. The glide, it's the top bowl gliding on the bottom bowl. Come on, Chan, you got this, buddy. Don't hang me out to dry.
The right side, Benny, you've got a closing down on the right. So you got you said that, right? Inferior,
yeah,
inferior medial.
Yep.
And then tell me, I just repeated basically what you said, but
that was a really smart thing to do, Chan.
I appreciate it. What was the question again?
I'm going to right side bending. Think about what is the right facet joint doing? What is the right oncovertebral joint doing on the superior segment?
So superior is going inferior medial.
Yeah, you got it. It's that bowl motion of going down and in. So it's going to go down and in this way as that superior bowl rocks kind of this way. In there. So we have this loss of range of motion. Now, this could be due to aberrant muscle activity. It could be due to co-contraction of some of the cervical stabilizers, changing the axis of motion around these joints. So, we think about it, we have articular restrictions, could be loss of inferior medial glide, oncovertebral joint, loss of extension of the right facet joint. It could be due to, again, aberrant motion because of the pain response, or it could be due to, again, co-contraction of the muscles, the splint around the neck. So I like to think about layers that, we want to get a sense of what the biomechanical state of this joint is, like we discussed in the previous few other ones. But if I go in there and I find that I have a normal joint glide or a hypermobile joint glide, it still gives me information like, okay, this motion segment can move normally. So I could have a sprained Basically what amounts to a sprained joint, like a traumatic arthritis in the facet joint, oncovertebral joint in the disc. I can have a muscle strain. There's other things I'd look for. But if I find that this joint is restricted, it's something that we'll work on in the course of being able to treat immediately. And getting that joint to move and kind of restoring some of those functions to get the motor control back in normal. So that's where this sentence kind of here, I hear this sentence right here that I'm highlighting. And I'm immediately thinking, I'm going to look at right extension, particular loss of extension, or if you're a medial posterior glide, you're restricted. So not always the case what you find, but it's nice as you think about inside bending. That's what has to occur as I go up the chain, eventually. So do I have a segment which is altering the pattern of movement around that? Left side flexion, left rotation, full range pain. So this joint's asked, and those joints that we just talked about are being asked to go into flexion or superior glide, let's say, then they generally don't reproduce the same symptoms. And again, here we have, none of the ranges produce spasms. And what this is telling us is that, okay, I don't necessarily have a muscular end feel. So I'm not getting a spasm end feel when I do this, but they had harder than usual end feel. In case with the right rotation is pathomechanical. Pathomechanical end feel is just a jam. You go to push on it and it doesn't want to go. You push on it and you just hit a barrier. So again, an idea of, I don't get muscle spasm. Now in acute cases, you could still get muscle spasm to guard around the joint. But in this case, what Trim is trying to tell you is that, okay, I don't have a spasm end feel, so it's less likely muscular and more likely muscular. Because the pathomechanical end feel is that of an articular end feel. Now I'm feeling good. Now we're back where Ariel wanted to be. She wanted to get in there, feel muscles, see if muscles were sore. She wanted to get her hands on these joints, see what the joint glide was like. I can read her mind. Or like Chan, she just told me it 20 minutes ago, so I know what's on it. And compression, traction, painless. Now you're looking at compression, traction as you're doing that. That would load the disc, the end plates, or in this case, oncovertebral joints, because it's designed a little differently. But it's also your classic symptom reproduction test if you're looking at compression distraction. Okay, did they get radicular symptoms with it? So I look at that and I'm feeling pretty good. Craniovertebral stress tests are negative. Craniovertebral stress tests are going to be what we talked about earlier. That's going to kind of get into alar ligament, transverse ligament, and pectoral membrane. Clean that up later. Again, here they went ahead and did cranial nerves and other negatives. Now we're feeling better about our differential VBI not being something we just missed. Biomechanical testing indicating a loss of extension with pathomechanical end feel or sublux to end feel. Right, C2, C3 in this case, zygoapophyseal joint, which was painful to test. You're going to see this joint a lot. And the reason why you see this joint a lot, if you remember when we covered upper cervical biomechanics, is that it's unique in the spine in that the anterior and posterior joints, or the facet joints, bear a fair amount of the weight. Where, a lot of the spine, the facet joints aren't really weight-bearing structures. But in C2, C3, there's still this balance of the weight being 50% of it being borne anteriorly, 50% of it being borne in the posterior elements, where that shifts as we get further down. There's less weight bearing in the facet joint, significantly less weight bearing in the facet joint, actually, more so in the disc. So when you get force coming through these joints, they're subject to more forces. And things. So as it gets arthritic, it's small, it's problematic. I think it's a common one I see in the neck. I'll find this one being arthritic in individuals, the myriad of different things. So not an uncommon one. And again, it's going to be coupled with right rotation. So let's think about right rotation as we do this. So when I go into right rotation, if I'm looking in a small range, I have occiput on C1, gives me that first 40 degrees of rotation. So again, right C1 inferior joint is going to glide posterior on C2. And as that happens, I'm going to go into extension on C3 on C2 on C3 on the right. So that rotation moment will be quite jammed, because as soon as the ligamentous system starts tightening up and I start loading into C2, C3, which would happen quite early probably in this individual in the range of motion, they'd be fairly limited. And again, same thing with the side, as we saw up there. So what is the prognosis in this one? Somebody else hasn't spoken. Tell me, what's the prognosis for this individual? We feeling good about this? We feeling bad about this? Or we don't know what the hell we're doing? Oh, come on. Don't make me calling somebody.
I'm feeling better about it. I mean, the symptoms are improving. And so I feel like that it's going to be more either capsular there, either manipulation, mobilization, with treatment.
Yeah, this is kind of the best case scenario for Chan. When you think about it, because this is something where, okay, I ruled out all the more serious things. Basically, I have not seen anything that indicates VBI, upper ligament strain. You know, there's nothing serious. There's no real sign of fracture. I don't have the serious things I'm feeling really good about. I can kind of go through this Illman script process and see that, okay, I'm good here. Did cranial nerve testing to see if they're okay. Range of motion matches it. I have a pathomechanical end feel at 2-3. The zygoapophyseal joint. That's kind of what I want to see. So, you know, this is kind of where we want to be now. You know, the only thing we may run into here, as we'll talk about it, is that there may be difficulty early on in treatment, depending what treatment we pick, because of inflammation around the joints. You know, Jim in here will talk further on that the absence of spasm may argue against the idea that there's inflammation. You know, sometimes the inflammation around the joint's angry. You will get more of a muscle guarding, muscle spasm reaction. Again, the idea that this person also responded to anti-inflammatories immediately is a pretty good sign. Anti-inflammatory responds rapidly to anti-inflammatories, whether it's a knee or something else. It tends to be a little better sign than, okay, they have something less noxious happening. So let's say we're 2 weeks out. What would be the preference of choice area? What would you do to them?
So yeah, it's referring from the cervical spine, and it's there. So what was it with the muscular? It wasn't as muscular, but a little bit, right?
Yeah, you know that there's always going to be a muscular component and articular structures involved, but we don't really feel it's a primary muscle, because when I do the muscle stress tests and those motions, I'm not getting muscular pain. You know, when I lengthen the muscle, it's not irritable. So when I go into full range of motion of left rotation or flexion, what I end up seeing is that, okay, well, if I lengthen a muscle that's been strained, it's generally painful. So that's where that range of motion kind of helps going to the left, because I know that, okay, well, that muscle did get irritable when I put it in a lengthened position and stressed it. Less likely muscle, really at C2, C3, right extension subluxation in a patient who's 2 weeks out from car accident.
Starting with some grade 1-2 mobilization through the cervical spine, light mobility exercises in prone, and adding in like a little bit of traction, suboccipital release, because it feels good. I'm assuming it normally does. If it doesn't, I'm changing their head position so they are comfortable there. If they're not comfortable laying flat. And then postural strengthening down up into the upper thoracic, taking off the strain from there as well.
By postural strain, how would you reduce the postural strain? Talking about that, what do you generally think of? What's your go-to?
Yeah, I mean, it depends on like where they're guarding and like what they're compensating with because of the pain. So typically you'll see that like forward head posture with the like slouched raised shoulders. So getting that repositioning of the scapula like in the upper thoracic region and then with after and before the ear mobilization to the cervical spine.
Yeah, it's kind of chicken and the egg one where somebody say, oh, well, if you have all this muscle toning, I can't feel the joint, but many times this joint is jammed, then you get the muscle toning pattern around it. So if I can get to the joint and get a sense of what the joint is doing, I'm not afraid to go in there and try and get this joint loosened up, get this joint moving. Now, I found to be more cautious with this individual. We often talk about we're not going to be able to tell with any of the testing and what we're doing in the upper cervical spine is we're not going to be able to tell if we have a vertebral artery dissection. Now in trauma, and this can happen in car accidents. It's been reported as high as 30% of cases that you see vertebral artery dissection potentially with car accident patients. So, with that is one thing we don't know because, we may get neck pain, we may get headaches, it may refer, you may get nothing at all. And many times what you get is nothing at all. But we don't know that we don't have that. VBI is easy because we're getting cranial nerve symptoms because it's the vertebral artery brainstem. But the dissection is what we don't know. So, Jim may be a bit more aggressive in going here. I mean, it makes, Eric and I, we'll talk about the same things. We do this, so it's consistent in what we do in the later modules. It's kind of like, I'll think about a 6-week window with somebody who's a trauma, something like this, about how aggressive I will be at a 2-3. I will tend to be more like you. I'll be less aggressive. I'm going to go a neutral 2-3 technique, maybe a traction, maybe a mobilization. I'm not going to use a lot of rotary force. I'm not going to use a significant amount of traction force. I'm going to try and get this joint free with a grade 3, grade 4 mob if I can do it. Many times you can by having clean setups. And we're going to practice that in clinic. If you do a clean setup on a joint, 80% of the time that joint's going to go for you without having to use a high amplitude manipulation. So understand the biomechanics of the facet joint, of the oncovertebral joint. By applying those biomechanics or how C2-3 is just a little bit different. You can get these joints to kind of free up. It's like unsticking a jelly jar. You want to do so we can get that joint to free up on its own without using a significant amount of force. So the better I get at manipulation, sometimes the less forceful I have become. Because I just realized that clean setup is where I want to be. So for this 2-3, what we're going to work on is a very clean setup in this manipulation technique, or mobilization. If they're coming to me and they're 2 months out and I find this, I'm probably going to traction manipulate. Davis 1, low force, load them up, neutral position, not rotating through upper vertebral arteries, very low traction. This person I think was 34, so probably low chance of osteophytes in the canal. So what I would do at week 2 would be different than what I do at week 3. And then we can talk in later on about where Ariel was going with what is the best pattern of then muscle retraining in this individual. Because if this is a 2-3 pathomechanical, they're probably going to feel pretty good when I get this joint moving. I'm going to relieve, I would expect 70 to 80% of their symptoms, hopefully, at that point. And then the rest may clean up over time. But what happens is that sometimes the muscle patterns that have developed in response to this pain don't always go away the same. You're left with a limp. And many times that's where that muscle retraining becomes super valuable in preventing chronic neck pain. Much like we talked about in the lumbar spine, so we don't have multifidi atrophy, changes in pattern, up-ramping of sternocleidomastoid, down-ramping of longus colli, longus capitis. That if we can then prevent that mechanism from occurring, it gives us better, potentially long-term outcomes. But the thing that the neck pain researchers kind of lament is the fact that this manipulation will give this person fairly quickly immediate short-term pain relief, but it may not give them the best 6-month, 8-month, 10-month thing because they feel like they don't need to do anything, and then they don't retrain the aberrant patterns. So we'll spend a little bit of time. I'm really working on with Matt and Michelle on how do we maybe get a little bit more of those retraining ideas in here so that you just don't leave here thinking it's a no manip situation, that you realize that retraining portion has an important place. Important, but sometimes it may be, I need to make sure the joint is moving properly first. You'll get people feeling pretty good with that. And good luck, for some of them getting the buy-in to doing exercise. That process makes sense. I'm gonna assume no.
It makes sense. I'm looking at reading the treatment thing where it says it'd
No.
be advisable to leave well enough alone.
I disagree. I left Jim's in there. I disagree.
Okay, yeah, I was gonna say I also disagree.
I disagree. It's okay. It's okay to
Yeah.
disagree with Jim. It's okay to disagree with me. It's okay to disagree with Eric. I have an opinion. I disagree. And that's kind of where I'm putting the other stuff in there, where I will leave it in there and you'll get conflicting opinions. And it's like, well, they're all over the place. They don't agree on things. Seldom do we. But I think it's really important to do that second phase. I think that's where I'd be. I think Ariel, from your experience, you see the same thing. Is I want to normalize the muscle tone, because what part of it is that with this individual, by doing the deep neck flexor exercises, I don't know it's so much about getting the longest colli capitis to get endurance and strength, but many times it's about down ramping suboccipital tone in this particular individual. That if I'm doing the
Well, and
deep neck,
also just like it, I mean, you see this is C2 is a little higher, but you all like I always see that like C4 through 6 seatbelt problem, depending
Mhm.
on where they were sitting.
Yeah.
And that doesn't seem to clear very well. And then just in general, like with MVAs, you have that guarding just getting back in the car. So it's not just the guarding from the accident, but also like continuously coming back every time they sit in the car.
Yeah.
And so working through kind of that as well.
yeah, because they have an abnormal co-contraction pattern or they develop an abnormal muscle synergy. So when they go and plug in their guarding mechanism, now all of a sudden it's loading the spine in an aberrant way, you have aberrant input through the proprioceptors. You know, it reinforces that give me that limp when I don't need the limp pattern in a way. That's where we're gonna kind of roll those concepts in. So that's why I'm glad you read that. And again, you're right. I disagree. I think this person then and get the joint manipulated, but then I want to work on the muscle tone and settling in everything else, getting everything else to equilibrate. You know, if I want to decrease some of the further and have a really great first session, I'd probably go in there and needle C2, you know, and do that. And that's going to take away some of that muscle guarding and soreness, you know, just by basically whether it's going to be the centrally mediated pain response that occurs from the release of serotonin at that spinal level. You know, is it inhibition of that muscle that's been hypertonic and increased blood flow to it? So it's more of a peripheral component. But I can get many of those same things with graded mobilization, you know, isometrics, muscle contraction. It can have those same pain modulatory effects with movement. So best to use it. So yeah, it's a really good point to go down the treatment. I'm glad you picked that up. And I'm with you on that. And that's in the course, we're going to work on that half of it too. That's where I want to make sure that it's, you know, as you write it out, it's all manual therapy, biomechanics, you know, assessment manipulation. But I want to make sure that we're kind of completing this to make you the complete package. It's the idea of the process. This is literally, if you're thinking, oh God, what's the oral practical? Like, this is the oral practical. It's the exact thing you look for. You look for sentences like this. I can move through these differentials. I can come to a conclusion. I can apply a treatment. If you had me as doing your practical and you get a case similar to this and you work through this chart, you do money. So don't worry about an oral practical. We're going to do plenty of these types of cases as we go on. We're going to work on this during the weekend. Just, you know, I'd love to spend a weekend doing this, but there's just so much also mechanical stuff. And this is our time together to really work on hand skills and develop that. So I want to be able to use the Zoom times to balance this clinical reasoning portion of it and making sure we have adequate skills times in lab. So we'll do a few of these in lab. But again, sometimes I find that if I run behind, start skipping this to do the manual side. Cool.